For a hospital stay, it's even more challenging. So yes, hospitals are required now to put out their pricing, but how many consumers really understand and how often can they really predict what services they are going to need when they go into the hospital? Might they develop an infection? Might there be complications? How long will they actually end up staying? You can suggest, your doctor will tell you, well, we think, you'll be able to go home the next day, but that's not a certainty.
That is Stephen Wagner, the Executive Director of Universal Healthcare Action Network of Ohio. For the past decade, Steve has worked to improve affordability, access, and quality of healthcare. He has given a voice to populations that are often overlooked and underserved. This is Act 3. I'm Michael Sentz, founder of CaringWire, and your host. On this episode, I'm going to make the case that innovation in healthcare requires public and private partnerships. I'm going to prove to you with stories from a man who has spent his life working in public and private posts to represent the voice of the customer. Along the way, we will discover why healthcare is so challenging and opportunities for change and improvement to Ohio's highest risk populations. All right, hello, welcome to Act 3. I'm your host, Michael Sentz, and on this episode, I'm thrilled to be joined by a leading advocate in affordable, accessible, and quality healthcare in the state of Ohio, Steve Wagner. Steve is the Executive Director of Universal Healthcare Action Network of Ohio, and since 2016, Steve has led the effort to secure funding that allows the Universal Healthcare Action Network of Ohio to achieve its mission and advocate on behalf of people who need access to affordable healthcare. So Steve, thank you so much for joining me today and welcome to the show.
Thank you. Yeah, it's great to be here.
The UHCAN is a mouthful. I almost stuttered there with the acronym.
Yeah, we tend to use UCAN, but yeah, it's pretty long. If it wasn't for the fact that within a lot of the circles of advocates and government were pretty well known, I'd change your name. But
well, UCAN is a great acronym that has a positive connotation to it. So I like that.
Yep.
So I'd like to just start off, I call this the breadcrumbs version. Give me the cliff notes of your story, how you got here, and really how the passion for healthcare developed.
Yeah, so I've been a public health advocate for a very long time and was in government service for a long time. And so this was a fun transition. So the nice thing about government is oftentimes you have some authority to make changes, but you always have a boss, right? And about what you can say. And so it's nice being in a situation now where the voice that I have is really trying to carry a consumer voice, is trying to carry the voice of the public. And so sometimes I say that, but more often than not, I try to just bring that forward so that people can speak for themselves to decision makers.
And so I noticed that you started your career in the state of Ohio working in healthcare and public advocacy, and then you transitioned to UCAN. Can you tell me about the mission of UCAN, and who does it serve?
Yeah, so we have a tendency, I think, as an organization to represent individuals that are faced with poverty. If for no other reason than, frankly, they have as difficult time as many in getting healthcare. And that's not simply a matter of affording the healthcare, but oftentimes their access, their ability to get to where healthcare is delivered, to navigate the system. So we do, though, because affordability affects everybody pretty much as you move up the spectrum of income. We do try and advocate for everyone having really access to care that is quality and affordable. So I think the other piece that's a hallmark of ours is that, oftentimes people with more income have better access to decision makers, right? They're used to working in businesses, industries where they have interactions with the executive branch, with the legislative branch, but people in lower income often do not. And so we do have that special effort to make sure that they can have an interaction with decision makers so that they can voice what their issues are, concerns, needs.
So that is a great transition. I myself saw my mother as a caregiver struggling to provide care for her aging parents over the last 5 years. So it's a journey that when it starts, it's a long process, it's a stressful process, and for certain income levels, it's debilitating, right? It can perpetuate the poverty cycle because you need to make the trade-off between whether you go to work or whether you deliver care. And so in the state of Ohio, for individuals caring for loved ones or dealing with illnesses themselves, what resources do you know, are you aware of, that can help people navigate these situations?
Yeah, it is really challenging, right? I mean, if you're engaged dealing with chronic illness, needing care on a regular basis, the healthcare system is not easy to navigate. So both the part of the healthcare system, which is the delivery of care, knowing where you get your care, what that's going to be, making predictions on cost, as well as the whole issue of navigating your insurance system or the payer system with that. It is healthcare literacy, which is understanding how insurance works, is not a particularly strong suit for many people. So understanding what your out-of-pocket limit is, what your deductible is, what a copay versus a co-insurance. I mean, that is very challenging kinds of concepts and words. And your plan changes each year, right? There's always something that changes in your plan. So being aware of what is a very large contractual document is very difficult for most people. And unfortunately, there are not a lot of resources out there to help you with that. So one of the things that we urge people to do, though, is to make sure that they're talking with both their insurance company to the extent that they have insurance, or talking with their provider about the bills that they have. So that can be both upfront when you're, I just actually had my annual physical yesterday. So I had a vaccine recommended to me. So it's, okay, do you know if that's covered by my insurance? And if not, how much is that going to cost me? So that you can make some decisions about that. And it might, and I'm sorry, I'm kind of going off, but one of the difficulties with healthcare is that it's different than buying certain other products, right? Because you're, for the most part, when a doctor says you really need this test or you need this medicine, you're faced with either paying the money or risking your health, right? It's not like you're trying to decide whether or not you're going to buy the cheap car or the expensive car or ride the bus. Yeah. So, yeah, go ahead.
And so that's really interesting to me because when I dug into what my mom was dealing with, I broke it down to 3 fundamental problems. It was education, first and foremost, understanding what she's dealing with today, what to do about it, and then what's likely to come next so that she can position and prepare herself and my grandparents to navigate that in a meaningful way. It was communication, both internal in the family with all the interpersonal dynamics that are associated with that, and then externally to clinicians and service providers. And then the actual navigation. Now that you know what you're dealing with, who is the right service provider or clinic or whatnot to go to and to get that correct treatment. What's interesting to me when you just said it's not like buying some of the other a good or service or a car or something like that. We really have the doctor who we place so much trust into, and we say whatever the doctor says goes, and we kind of follow their orders. I feel like it's really a asymmetric information marketplace, right? The consumer isn't armed with the resources and the information to make a counterpoint or to suggest a different pathway or to choose it for themselves. And so they're forced to just accept and go with the flow, even if that flow bankrupts them.
Right.
And so what makes healthcare different, that unlike travel, where you go to Expedia or Priceline and within a couple clicks of a button, you know the options, the prices, your pathway, how long it's going to take. What makes healthcare different in that regard?
Yeah, actually, I think travel is an interesting one to bring up because there's some variability in travel too that might not be in other products or events. And I think that's so. First of all, you mentioned maybe the certainty of costs, and it wasn't so long ago that when you did booked a flight, you didn't know what the tax and what do they call them? The boarding fees were. You saw what the rate was going to be, but you didn't know until you finally booked the ticket what your final ticket price was going to be. And that changed recently, right? That was very different in terms of booking an airline. For a hospital stay, it's even more challenging. So yes, hospitals are required now to put out their pricing list. That's federal law. But how many consumers really understand, and how often can they really predict what services they are going to need when they go into the hospital? There's, might they develop an infection? Might there be complications? How long will they actually end up staying? You can suggest, your doctor will tell you, well, we think, you'll be able to go home the next day, but that's not a certainty, right? And you might end up having other tests. So, it's really the piece about information that you brought up in the beginning is not just the asymmetry in terms of the fact that the providers have much more information than you do. It's also that some things are just not well known until you do them, right? Until you start down the road of a treatment, you take a test and then you're going to go from there, you take the next test. So it is really challenging to think about that in terms of cost.
I saw some surveys that UHCAN issued in 2015, 2016, and the results suggested, we don't really need to get too much into the numbers, but 63% reported their care plans did not include services, supplies, equipment that the members needed. 67% stated that their care team did not include their providers, friends, or family. So when you say you're talking about the hospital, great example, very ambiguous what you need. And on the clinical route, that's really hard to predict. But in the post-acute space with equipment, supplies, or auxiliary community support, isn't that a little more predictable?
Yeah, I don't know so much. So I think you still have varying needs. So especially if you've got chronic illness, the needs that you might have in being cared for at home may turn out to be different over time. So I think it is also that way that there's just this ambiguity that occurs.
And so when looking at the types of innovations or policies from your standpoint, as a result of the surveys and of the data that you continue to collect, are there particular issues or innovations that you value more than others?
Yeah, so one of the things that we pay a lot of attention to, and that was related to the survey they were doing. So we looked at individuals that are dual eligible Medicare and Medicaid. So many of them had significant disabilities. Many people were trying to live in their community in those circumstances. And I think issues around innovation in terms of allowing people to continue to live in their home and be in their communities are really important and really challenging, right? Because I said both community and home because sometimes what people think need to be provided is simply, well, you're in your house, you get to stay in your house, and you've got a nurse that comes by or a direct care provider, and that's all you need. That's going to take care of your health. But it's not enough. People still need to be able to have that access into the community, that mobility into the community, and those the connections, the ability to go shopping, all of those things are critical for people that are being cared for in their homes.
And so unpack that a little bit. Who is responsible for providing that access, which we know social determinants and your social well-being contributes to a significant portion of your quality of life and your overall healthcare, which obviously relates to cost. Mm-hmm. So who is responsible for providing that?
Yeah, I think so I think we are finding that if we want to provide high value healthcare, in other words, not getting good health outcomes for the amount of money that we're spending, we need to pay much more attention to that environment that's there. So whether that's the environment we need to help create for a person who's no longer being cared for in an institution, but is instead able to live in their home, in their community. So paying attention to those social pieces, or it's frankly the social needs people have. Take infant mortality in Ohio, where we have a significant problem with infant mortality for Black children. That is a function of, again, the environment out there. And we are never going to have good health outcomes until we start addressing those social environmental needs. So who's responsible? I think that in part, the insurance companies are responsible for doing that when they're contracted. So whether that's going to be a Medicaid managed care contract or it's private insurers, I mean, they're starting to think that way because in the end, it should help them lower cost, right? It costs less for a person to be in their home than in an institution. So let's take some of that savings and make sure we're providing better care.
Love that. Love that answer. When it comes to solutions to address some of those social needs and keep people in their homes, in their communities where they have familiarity, where they already have some strong relationships, is it technology that is a potential solution? Or is it more of the traditional manpower, social workers, home health care, and kind of build a support network of actual human beings around these individuals that need the care?
Yeah. So I think technology can help, but it can also be, I'll say, a barrier, a threat. And let me give you an example, and then we can talk about people. So in Ohio, as in some other states, the way in which they're monitoring and, in a sense, working the billing for direct care providers that come to home is a system called EVV, electronic visit verification. And they're basically using a cell phone type piece so that when you go and visit someone to provide care, you log in, you can put your hours, you can put the codes about what you're doing, and then when you leave, you log out. So it records that you were actually there. So that sounds all great, right? It's all electronic. It should verify all the billing. It prevents what is sometimes a perceived fraud situation, but most fraud is committed by providers and not by, clients who are just trying to get care in their home. So it's a misplaced kind of I think need for accountability, but nevertheless, it's there. Now, here's what people who are in their homes are thinking about that. Not only do these people come to their homes to provide services, but they take them places, right? They take them into the community and move around. And in this circumstance, these phones have a GPS. And it's like, why am I having to share my location data and where I go with the government? And wait a minute, it's a phone, so it has a microphone and it has a camera on it. Are they able to take pictures in my home? So there's these privacy concerns that come up simply because this technology is being used.
Is that the feedback that you're receiving?
Yeah, go ahead.
Is that the feedback that you're receiving, is that a lot of the community that has these EVVs implemented are perceiving it as a threat?
Yeah, there's definitely a portion of the community that's very concerned about that. Absolutely.
Now, I want to circle back to the human piece of EVV. Is something, as CaringWire starts to engage the supply community, and that's home healthcare agencies, meals, transportation, residential placement facilities. I've heard a lot about EVV.
Yeah.
And one of the biggest complaints that I hear from it is the billing side, is that depending on the provider, the structure of how you report your visit and submit your claims is different.
Mm-hmm.
And some of the fraud that you brought up earlier isn't necessarily fraudulent claims being submitted. It's, a box checked here or there that is, submitted to Aetna. How it's submitted to Aetna, you're actually submitting it to Molina or MyCare Ohio. It is different than Buckeye. And so the individuals have such a burden, the suppliers do, to get all this accurate. Is that being addressed in any way? Or is the government or the payers hearing these complaints?
No, that's exactly an issue. So in Ohio, they haven't instituted it yet because they're not getting the matches that they need between EVV and the billing with enough veracity to know that, the problems that you spoke about, which is that maybe the business rules aren't defined right for EVV, that they jibe with the way the provider works. And that isn't anybody's bad intent. That's simply that the systems weren't designed to talk well to each other. And I think that's, that was the underlying problem with the release of this system and the consumer problems, right? So they apparently have the camera disabled and there's all these protections in there. But if you wait for people to raise that as a concern to tell them that you've taken care of it, you've lost, right? You've lost their trust because now it sounds like you're just making excuses instead of coming out and saying, with a product and saying, we've designed a product that we believe will do this effectively and be secure for you, right? And then you're going to feel like your safety, your security was considered in the development of it. Right.
Yeah. So it's integrating the individuals into the change process instead of looking at the back end process.
Yeah. Oh, exactly right. I mean, nobody wants to have something thrust upon them like that. Whether you're the provider or you're the client that's having all this done, they want to be participative in it.
And so tell me about how do you get this feedback? Because engaging this population and driving up utilization rates of already existing plans is such a challenge, right? And, the numbers show that if you can engage and you can deliver information and services, it has a profound impact. But actually penetrating that community and getting the tools and the frameworks that they need to empower them to make decisions or to connect with resources is very difficult. So how do you can go about even collecting that feedback, and what have you found effective to engage these populations?
Yeah, no, you're absolutely right about the challenge that exists there. I think one thing that many people will say in common is that they might not be money poor, but most people feel time poor, right? They feel like, oh my gosh, how am I going to do all these things? There's always choices about your time. And that is true to an extent, but people who lack wealth also have a substantially greater lack of time. So we always do have to sell people on why it is important for them to provide their experiences and share their experiences. And that comes in two parts. One, that validating that what they know and what they experience is important. They need to know that. And then they need to know that they're actually going to be listened to, and it makes a difference. Because too often they see that public comment is a way to check a box and then move on, and then it's not listened to. So we have to address those two things. And I think by being an organization that's out there pushing the views we hear from consumers, I think we get around some of that because they understand that we value what they're saying. And they also understand that we're going to carry that and we're going to push those messages and try to advocate for change.
And so tell me about the actual execution of that.
Yeah.
How do you engage the individuals to share their experience?
Yeah. So it happens a lot of different ways because people have the time and have the capacity to act in different ways. So we go to church events. We meet with health ministries. We'll go to health fairs. We interact with community health centers who are treating individuals with the different care arrangements. We'll distribute out a survey. And when we do a survey, we try to make sure and do a short survey and a long survey. So for the people who really want to geek out on stuff, and they just want to say, so we want to say, well, what are your transportation issues? And what are your prescription drug issues? And whatever, they can answer that. For people who just want to say a few things and be done in 5 minutes, we usually also have a what's going right, what's not working, and what do you want to do? So that people can just answer that. And that's usually, if we're in a face-to-face setting, that's the piece of paper we give them. It's not it's not something that's drilling down into every little thing. It's just a way of getting what's top on their mind.
And so it sounds like you must have an organization of 1,000 people to do all that.
We do, and you're looking at 999 of them. Yeah. So no, we have a lot of partners that are very interested in this, but oftentimes,
partner network.
Pardon me?
Tell me about the partner network.
Yeah. So first of all, we have staff in Cleveland, Columbus, and Cincinnati. So the three largest metropolitan areas in Ohio, and that gets us some good urban connection. But we have we work with a group called Ohio Consumers for Healthcare that has a number of organizations, faith organizations, healthcare, legal aid, policy people that are interested in a broad range of anti-poverty kind of issues, and particularly in health. And so we reach out to them, and they have their own mailing lists and individuals, and so they help to distribute material. And then we reach out to organizations like in Ohio, there are organizations that focus on alcohol and drug addiction treatment, specifically in minority communities. We reach out to other alcohol and drug. We reach, anybody that really touches the population that we're after. We try and reach into the leaders or the engagers of those organizations.
Now, tell me about public-private partnerships.
Yeah.
So a lot the organizations that you named seem to be, at least from name, nonprofits and governmental type organizations that are health and advocacy and things like that. We've seen public-private partnerships really drive innovation in some areas. I'm curious your thoughts on that here and what that process looks like.
Yeah, there are times that we work with, for example, the insurance companies because our interests are similar. So, for example, the expansion of Medicaid is in the interest of the insurers and the hospitals and consumers, and that's that. The expansion of Medicaid is that the eligibility criteria are expanded to a higher income level than previous. And Ohio did that. Not every state did that. So that is an example where we all work together because we believe that it was something that would improve not just the health of Ohio, but actually the economics in Ohio as well. And I think that was pretty effective. And unfortunately, we've actually had to defend that policy decision multiple times over the past 6 years. Generally, we actually don't work as much with private corporations because we're not as involved in the insurance products that employers have. And so it's just not as they don't generally have all the same interests that we do. Now, we do sit, around the table oftentimes with provider interests, whether that's long-term care, hospitals, physicians, otherwise, particularly when it relates to patient safety issues.
And so I'm looking at my Care Ohio membership experience survey, the final report. And this might be a bit dated, but the recommendations, some of the top categories: care coordination, self-direction, DME, durable medical goods and equipment. Those I love seeing that because really over the last 18 months, I've talked to hundreds and hundreds of caregivers. I've participated in surveys of thousands of people with age-friendly Columbus, and those continue to rise to the top. And when I think about the impact that I want to have with CaringWire, it's to empower individuals and caregivers, which a lot of time bear that burden of care and advocacy for their loved one. And the other, and that's kind of the self-directed nature, right? Empowering them to make the self-directed decisions with the knowledge of choice and the knowledge of the different options that are available to them. DME obviously has profound impacts if applied successfully. So, from that perspective, it seems like a lot of overlap between the public and private missions, although I'm not particularly clear on the processes and the pathways to, go about executing in that realm.
Yeah. I think some of it is also the challenge that sometimes the best way for a business to make money is to satisfy consumers. But we talked about how healthcare is different, right? And sometimes it really just is that the consumer doesn't have as much choice. And so customer satisfaction sometimes is not always there, or there are barriers that are put up. So, the process of being able to self-direct your care sometimes can be too daunting for an individual to do, even though it would provide them with better, satisfaction would be more, they would determine their care. The bureaucracy behind doing it can be super challenging. So there's lots of reasons that we don't well align the customer with the people providing the healthcare and the service.
Are there, thinking about the journey and the aspects of the clinical setting versus the kind of healthcare support setting and then the social service or community environment, are there, out of really those three to scope it, does one stick out where the self-directed, educated pathway is an easier entry point and also would add the value that all the stakeholders are looking for?
Yeah, I'm not certain I can directly answer your question, but I think, one of the reasons that we need innovation so much is, you know, um, two things. One is that the healthcare needs and overall as a population are changing, right? We have aging populations. We have um, more people living with chronic conditions. Just the way in which care is necessary is changing. And then I think people's expectations are changing. Um, we have more of an expectation of service on demand, even in the healthcare industry, right? I mean, that's the part of the success of the minute clinics, or part of the reason I think that people do have an expectation that they should be allowed to age in their homes rather than being in an institution. But all of those should help drive the healthcare system to innovate and change and interact with consumers. And those are pretty powerful forces that are shaping other markets, right? those kind of expectations. So we should see it happen in health. I think it's just people. Well, take Ohio. Medicaid is a provider for health care for 2.6 million of the 11 million or so residents. Yeah, that's a big battleship to turn. Medicare, the same way. So, all of this health care that's driven by, in a sense, a relatively few payers is difficult to turn.
Yeah. So, a few minutes remaining. So, I want to ask about your vision for UCAN, what's on the horizon, and really the feeling that you want to create for the population that you serve and the legacy that you'd like to live there.
Yeah. So I think the thing that I would really like to see happen is that you can, we in our advocacy pay more attention to equity and changing it. Okay. So I'd spoken before that Ohio has some pretty significant health disparities. And so what that means is that a white man is much less likely to have hypertension than a black man in Ohio. A white woman is less likely to lose her child in childbirth than a black woman. Those things occur because of the environments that we've created, and we've got to do things to change those environments to change it. Because I believe that everyone should have that same opportunity at health, and we have structural, whether it's structural racism or other isms that we've created that cause people to be less healthy for reasons that have nothing to do with who they are as a human being. And we need to start addressing that. And I think the healthcare system, insurance, and others can start to do that. I mean, we have a Medicaid system that takes care of in total 2.8 million people, we should be able to make some pretty significant changes if we paid attention to equity instead of, I shouldn't say instead of. So we have there's the saying, rising tides raise all boats, but that hasn't worked in healthcare. We have continued to, so in Ohio, we just saw a decrease in our infant mortality rate, but yet we retain the differences between black and white children. That's just wrong. That just tells you that changing our healthcare system on a broad way is not going to work. We need to do it in a very focused way to basically promote equity.
So in a perfect world, there's a lot of tentacles to this, right? There's a whole policy discussion that we could probably go into in an entire episode. But in a perfect world, how do we get from where we're at today with such equity disparities to a future where equity is distributed equitably, healthcare is accessible and affordable within reason?
Uh-huh. I think we get there by starting to be explicit in our considerations. So, for example, the Ohio Department of Medicaid is going to rebid their managed care contracts. So the contracts that cover 2.6 million lives, they're going to rebid those contracts. They have incentives in those contracts right now that reward an insurer if they improve, for example, hypertension screening or some diabetes measures or other measures. Well, instead of rewarding them for doing that, what if we rewarded them for changing the disparity? If we really want to focus on this, we need to put our money where our mouth is, and we need to put our incentives there. We need to all keep our eye on that ball. So that's one way. The second is when we're creating policy, whether that's in the state legislature or in the executive branch, we should be looking to see how that policy impacts on equity. Let's just, talk through it, because we certainly talk through how policies impact on businesses or tax code or any number of other things. And we're going to only make changes if we start thinking about how it impacts on equity. So those are discrete things I think we could start doing.
Yeah, big vision. I like it, Steve. Well, I can't believe our time has already come to an end. That really flew by. I really appreciate you coming on the show today, Steve. Tell us where we can learn more about your work and what you're doing at UHCAN.
I think probably the best place is to go to our website, UHCAN Ohio.org, and sign up for our newsletter. For the most part, that's about action alerts, ways people can voice what they think about healthcare and be involved. So, yeah.
Sounds great. I also recommend to anybody interested in looking up those survey results. Steve has put out a couple articles on LinkedIn. Don't blow him up in his inbox, but check him out nonetheless. So, Steve, I want to thank you again. My name is Michael Sentz. Thank you for joining us. We'll see you next time.
Thanks, Michael.